you so much, and thank you to everybody for coming today on this very cool morning. It's really great to be here. I'm going to go straight into it because these are very short talks, designed as short talks. So there is a handout available, which is basically my slides and some extra comments, which is available on the front desk as you come in to register. So across Australia right now, there's no question that there are many stories of distress and despair experienced by people who seek mental health support. And those questions and those challenges caught the attention of the National Mental Health Commission, particularly the middle one in regional New South Wales, where a person died. And our team was commissioned by the National Mental Health Commission to guide some national and state policy thinking about person-centred approaches. And essentially the brief was to gain more detail, more clarity on how service providers, consumers and carers see person-centred, consumer-directed care in practice. So this is mental health and suicide prevention specific. And we went away to work out essentially what you see up on the screen, the fundamental answers to the questions that are up there, but also, given it's the National Mental Health Commission, how can the National Mental Health Commission give guidance to the states and territories all the way down to the local health networks about these really important concepts? We also spent some time teasing out conceptualisations of consumer-directed care, which is really the foundation of the NDIS. So the interface with the National Disability Insurance Scheme was really part of our brief. And we paid close attention to, inside the report you'll see a literature review, we paid close attention to these two concepts, person and family-centred care approaches, and certainly my comment there about consumer-directed care, and in fact there's been also a Senate Selecting Committee inquiry into the NDIS and the principles of person-centred care and consumer-directed care. So in thinking about these concepts, we framed it around consumer-directed care, giving individuals greater decision-making capabilities. I mean, this is what people want. It's a way in which types of care have been designed. And cash for care is sometimes used as a phrase to describe that sort of interaction with services. And yes, it involves budgeting and marketisation. And as I say, the NDIS would probably be the most prominent form of that. So we undertook a series of interviews with people across Australia who are receiving or delivering care. And we had 50 people from across Australia, representatives, but also working within a range of services, drug and alcohol services, the various offices of the chief psychiatrist, psychiatric practitioners, Aboriginal health services, clinical psychology, carer advisors. These are all specific roles in the mental health space, particularly consumer advisors and peer workers. That's probably the fastest moving thing in Australian mental health and suicide prevention right now is lived experience workforce. And we wanted to know what they understood about the concepts, the range of services and outcomes as they saw it, but importantly, the barriers that exist to implementation. So we're thinking systems now. National Mental Health Commission giving guidance to the states and the territories right down to the local health network, and using thematic analysis, we were interested in the shifts, examples of good practice, but also the shifts, conceptually the barriers and practice examples which produce positive outcomes. And we had a co-design process. So someone outside of the research team was engaged in the co-design process with all of the data as it was thematically understood. 3 90-minute online sessions with a facilitator, as I say, external to the author team. And this is probably the most compelling part of the talk, because what we've been able to do, which is explained more fully and comprehensively in the product that we did for and publicly available for the Commission, is around those particular themes and shifts. So you can see here what people are saying across Australia from a group of 50 about what shifts are needed, particularly the challenges and barriers and the issues and the shifts in practice approaches. Shifts in leadership, things that we've talked about already, shifts in lived experience integration, and certainly shifts in the way in which empathy and supportive relationships are understood, the highly relational practice of mental health and suicide prevention support, and creating safety for people in suicide-related distress or at risk of suicide harm. We're able to do this based on the work of the co-design process, but we're also able to say that these shifts could be kind of highlighted by the need to shift power and move towards more decision-making, shared decision-making in particular, where services are flexible and care is tailored to the person's wishes, preferences, and a whole range of things which are consistent with the concept of recovery, personal recovery and mental health. So living a life with meaning and purpose, living a life that is a flourishing life, having that across all compass points of a person's life, the relationships, roles and connections, were certainly a takeaway from the perspectives of people who participated in this piece of work. And particularly around practitioner actions to promote safety from multiple perspectives. So we think about safety, and particularly suicide safety planning is a good example of that, making a plan for future safety, but also negotiating early and renegotiating power relationships around risk, and planning collaboratively without the use of coercion and coercive practices, which was really the trigger point for this piece of work. But we also were interested to see how the potential improved psychological and physical shifts in safety. And I cannot overemphasise that this is a system and a workforce that we're talking about. Better respect, empathy, trust in practitioner, consumer and carer relationships. I think this is so compelling, and we really were very pleased about this. And I can say in South Australia now there are 2 new policy directives that have emerged. One is we now have in South Australia a suicide prevention pathway across the state where these principles are now embedded, and currently not yet finished but recently out for public sector review and commentary was the Shared Care Equally Well process. Again, where these processes, Shared Care Equally Well is about physical and mental health being equally prioritised for people with a mental health condition. But there are also challenges and barriers and issues, and you can see there's a long list there, but I guess I'll highlight specifically again for the mental health area. It's a really challenging part about risk. Too much focus on risk, inconsistency in practitioner skills, stigma and stereotypes about people with a mental health condition, rigid over-control with services and flexibility as well. Paternalism links to that as well. So through that analysis and co-design, we identified 8 core system shifts needed to enable policy change. So this have been adopted by the Commission and now gone out to the states. And certainly having a wide-angle lens, a greater understanding and empathy around interpersonal communication, consumer and care involvement and engagement, supported decision-making practices within mental health legislation. So we now have that in the South Australian legislation. We have a Suicide Prevention Act now in South Australia. We also have, as I said, the Suicide Prevention Pathway. Strengthening lived experience leadership in service governance and in the workforce, that's been a very big one. And certainly that really headline focus on relational recovery and crisis response models that emphasise dignity, personal safety, choice, engagement, these things all integrated for the best pathways within care systems. I mean, these are the things that are really embedded now in our suicide prevention pathway. One of the big shifts that we found, and we've since done further work on, is how people with lived and living experience of mental health challenges and suicide-related distress work side by side with mental health colleagues and clinical colleagues. So we did some preliminary work around that and did a review to sort of talk about that. Pleased to say that last night the MRFF announced a grant to take this further. So that grant will be in South Australia. We'll be working with across a range of areas. The 3 South Australian universities are embedded in that. The good people here at SAHMRI are part of that. There's a big group of people to actually develop a model of care where people with lived and living experience of distress and suicide-related harm work more closely at a systems level, so a statewide systems level, which might have some national implications, and we thank the MRFF for funding that. The next piece of work is in the National Suicide Prevention Strategy. So the National Suicide Prevention Office and the National Mental Health Commission work very closely together. So I've accepted a responsibility to contribute to person-centred outcomes around suicide-related harm and particularly aftercare for people who have attempted suicide. And that piece of work, it will be embedded in as a result of this strategy. The strategy was released in February this year. I'm really pleased it's a 10-year strategy. So we are really talking across Australia how we can think about these things in a more thoughtful and considered way, but at the same time have some really good science that sits behind it, that in this case is specific to the phenomena of suicide, which is a very complex phenomena. There are no cash and carry answers in these sorts of fields, but at least this takes us a step closer, and I'm very happy to work with the office to be able to do that. That's my talk. Thank you very much.